Oversight Board. I'm Glyn Jones, Deputy Mayor of Doncaster, and I would like to welcome you all to today's virtual meeting. This is not a public meeting, but a meeting the public can attend. The meeting will be recorded and shared online following the meeting. Item 1, welcome, apologies and absence and introductions. I've already introduced myself. I have received apologies for absence from Councillor Nigel Ball, Councillor Nuala Fennelly and Jackie Pedersen. Mayor Ross is attending a regional meeting and is hoping to join us later in the meeting if possible. Are there any other apologies for absence, please?
No, Chair, I haven't got any more apologies.
Okay, thank you very much, Rachel. I will now introduce the members of the board present at today's meeting. Can you please introduce yourselves to ensure that you are in attendance and can hear the proceedings? Councillor Jane Cox.
Yes, here, Chair.
Thank you, Jane. Councillor Chris McGuinness.
Good afternoon, Chair.
Thank you, Chris. Councillor Jane Nightingale.
Good afternoon, Chair. Councillor Jane Nightingale present.
Thank you. Councillor Andy Pickering.
Present, Chair.
Thank you, Andy. Damien Allen, are you in the... I can just see.
Present, Chair.
Thank you, Damien. Dr. Rupert Suckling.
Yep, present, Chair.
Thank you, Rupert. Chief Superintendent Mel Palin.
Yeah, I'm here.
Thank you, Mel. Shane Totty. I can't see any indication.
I can't see Shane, Chair.
No, thank you. Dolly Aguro.
I'm here. Thank you, Chair.
Thank you, Dolly. Fiona Campbell.
Here, thank you.
Thank you, Fiona. And Paul O'Brien.
Present, Chair.
Thank you, Paul. We also have a number of officers present from Doncaster Council who are in attendance to both support the meeting and to respond to questions from board members in relation to items on today's agenda. Can I ask that when you are not speaking, could you please keep your microphone on mute? May I point out that the microphones of external attendees, such as members of the public and press, will be muted during the meeting, apart from when they are putting their questions to the board. If anyone intends to record today's meeting, please ensure that this does not disturb the conduct of the meeting. Finally, please ensure that your mobile phones are switched off or onto silent mode. Thank you. I will now commence the meeting. Item 2, exclusion of the public and press. There are no items on the agenda where the public and press are to be excluded. Is that agreed?
Yes, Chair.
Thank you. Public questions and statements. I can say that we have received no questions or statements from members of the public for today's meeting. Item 4, declarations of interest. Are there any declarations of interest, please? Okay, thank you. That I cannot hear anybody following the 4-second rule, so we'll move on. Item 5, minutes of the Doncaster COVID-19 Oversight Board meeting held on the 9th of December 2020. Can they be moved as a true and accurate record?
Yes, Chair.
Yes, Chair.
Thank you, Robert. And that's agreed?
Agreed.
Thank you. Item 6, COVID-19 national overview. I will now ask the Director of Public Health, Dr. Rupert Suckling, to present this item. Rupert, if you would please.
Thanks, Chair. So we last met on the 9th of December as a board, and a week seems a long time in COVID, and certainly 7 weeks is a very long time in terms of what's been happening with COVID. So when we met last, we were in Tier 3, and our rate per 100,000 people was 205. Per 100,000 people, and we were experiencing at that time, as the rest of the country has experienced, was a further increase in the number of cases. So you may remember in Doncaster we had a very high rate at the end of October, beginning of November. That had been falling through November, but when we last met, it had started to sort of flatten out. And what we saw through December was a gradual increase in the number of cases. And we were certainly expecting over the Christmas and New Year period to move into higher levels of restrictions. But as it happened, the whole country then moved into national restrictions, if you remember, the 6th and 7th of January. So we're now sort of 4 weeks on from the Christmas period. So any effects of Christmas mixing should be out of the system. And we're now 17 days into the national restrictions. So we should expect to see those national restrictions start to have an impact on our overall rates. And Laurie will be talking us through those in the next item. It's fair to say that as well as the challenge with this peaking cases over the Christmas period, we've seen challenges with the hospitals being busy and increasing number of excess deaths, but there are some glimmers of hope for us. So in particular, Laurie may touch on the fact that the numbers or the number of cases in Yorkshire and Humber are much lower than we're seeing through the rest of the country. So places in the southeast and London had seen rates maybe 5 or 6 times what we'd seen in Doncaster, and their hospital and care systems had definitely been impacted much worse. So from our perspective, it's good that our numbers are relatively low and that we are benefiting in terms of a public health perspective from the national lockdown. The other sort of good news is the approval of vaccines. So that was just about to happen when we last met in December, and I'm sure Anthony will be able to update us under item 8, the control plan in terms of where we are with vaccinations in Doncaster. That's good news. I think the only caveat, Chair, is that obviously there are unintended consequences of the lockdown. So potentially the risks around mental health, social isolation, and the impact on the business community. This isn't the same lockdown as we had in March. It's not the same as the national restrictions. So people are still able to meet as part of support bubbles. The NHS is still open for business, so primary care is still open. And a number of third sector groups are still able to meet in a COVID secure way, but we should still be mindful of the potential of the impact on lockdown. There are 2 sort of dates that people are talking about nationally. One relates to the opening of schools with a decision potentially being made this week or next week about whether primary schools in particular may reopen after half term, although from what we're also hearing is it's unlikely that any schools will reopen till after Easter. And then the second date that we're hearing about is the 8th of March, and the 8th of March is 3 weeks after the top 4 groups for the COVID vaccination will have some immunity from that vaccination. So I think what we can take from that is that the lockdown is going to extend beyond the middle of February. I think many of us locally felt that it would always be longer than the middle of February, given the time it takes for the rates to come down. But obviously nationally there needs to be a review on that. So ahead of our next meeting, which is in February, Chair, we expect to hear further information about the extension of lockdown. So it's very much a sort of steady state at the moment from the national picture, Glyn. The lockdown is here. The numbers are coming down, but they're coming down very slowly, and the impacts on hospitals aren't. They're not lessening quickly either. But happy for any questions on the national overview ahead of Laurie taking us into some of the local data in the next item.
Okay, Rupert, thank you. Board members, if I can ask you to indicate if you wish to raise any questions in relation to this item. May I also remind members to mute your microphone when you've concluded speaking. Does anybody wish to ask Rupert any questions? I can see nobody indicating Rupert. Oh, Paul.
Yeah, thanks, Chair. Yeah, Rupert, the impact on schools. I understand, obviously, there's a decision to be made and it is looking likely that they might be around about the Easter time. I think the problem that we're having on a survey that the GMB's done recently, I think the results came back yesterday or Saturday, is that the number of people with COVID cases in schools is in the teaching assistants and support staff. It's a far greater and higher number in those particular groups than it is in teachers. And I think we're seeing that because obviously teachers are being allowed to work from home or deliver blended lessons from home. And I think our members feel that they're the ones that's being placed at most risk. I think it's trying to understand, what do we do for those schools that are staying open in terms of trying to make those staff feel a lot more safer, or a bit more equilibrium brought to the amount of staff that are attending or in the workplace at any one time. But at the end of the day, they're the lowest paid staff as well as, but being placed in a significant risk. And our data is showing that they are the ones that are getting the COVID more than anybody else within school. So it's an issue for that staff group.
Thanks, Paul. Certainly, there are going to be very difficult decisions about schools and when they reopen and how they reopen in a safe way. We are seeing some of that local data. We don't get it from every school, but certainly the data that I've seen recently actually does have more teachers positive with COVID than other support staff, but that may be just a reflection on the sample that we've got and may not relate to the whole piece that you've seen, Paul, but I'm sure there'll be lots more to discuss about schools as we go forward.
Andy, you've got your hand raised.
Yes, I don't know if it's just a question for now, Rupert, or whether it'll sort of crop up later on in the meeting, but could you tell us what the vaccine supply situation is?
Yeah, we'll cover that off later in the meeting if that's okay, Andy.
Yep, fine.
Okay, I can see nobody else indicating. Oh, Damien, you just snuck in at the last second.
Thank you, Chair. I'm just conscious that you outlined what effectively is a bit of an extension around the formal extension of the lockdown, anticipated sort of exit being a little less clear around a strategy. From a public health point of view, if we've learned anything from the previous lockdowns, one of the key issues is coming out too soon. Premature relaxation, I think, is how it was described in the press today. And actually the evidence seems to suggest that, and this is the paradox really, is that you need to eliminate the transmission. And just as we're ratcheting up the testing, and particularly asymptomatic testing, the paradox being that those other factors that you talked about in terms of impact on business, social isolation, mental health, parental support to children at home, Where would you draw the balance in terms of both the duration of the lockdown and the style or the approach of the relaxation?
So in terms of the sort of public health measures, in particular the lockdown, it needs to be for as short as possible time, but as long as enough to be effective. So if you remember in Doncaster in the summer, we were down to we're in single figures in terms of our rate per 100,000. Our positivity rate was well down in terms of under 5%, and to all means and purposes, that means there's zero community transmission. So we should definitely aim to have zero community transmission and aim to eliminate the virus. We should take advantage of the fact that our rates are relatively low compared to the rest of the country to do all that we can to break the chains of transmission and to drive the numbers down further. So that means that we need to make sure that not only are we in the lockdown, we are abiding by the rules of the lockdown. So that's the public, but also businesses being COVID secure and operating in that way. If we have symptoms, we need to self-isolate and to get ourselves tested. And we also then need to keep to the hands, face, space, and also look at ventilation, particularly in this period in the winter, Damien. So we should take advantage of our relatively low rates and see that as an opportunity to eliminate the virus rather than an opportunity to ease off relaxations. If that requires us lobbying central government for additional support for sectors of the economy that are poorly supported, then that would be my preference, as opposed to letting the lockdown come off too early, because if we have a further rebound in cases, that will just be more difficulty and more misery for the economy, Damien.
Thanks for that, Rupert. And particular sectors that you mentioned, obviously of concern, are hospitality and leisure, who since the October period have been impacted by one set of restrictions or another. It certainly feels like we ought to be lobbying for more support.
Yeah, it's those sectors and then those that are on 0 hours contracts and have difficulty evidencing. So that they're therefore difficult to get support from central government, because there are grants, but we've seen with the self-isolation payments, the number of people that aren't eligible for them is quite high.
Okay, thank you.
Okay, thank you. Paul.
Thanks, Chair. Rupert, I just want to pick up on the ventilation. I mean, that has been something that's been talked about for quite a while. I'm sure you'll appreciate from a trade union perspective, we've been quite objective towards where vehicles are concerned, because the view from our part is that the air goes in before anything starts to get pushed out. So there's more likelihood to actually push the transmission around before it comes out of the vehicle. But the point on the ventilation is that there's a case that's been proven in the press in a country that's got a far superior track and trace system to us, whereby a gentleman was sat 20 feet or 20 metres away from somebody else who turned out to be positive with COVID. And the person was sat underneath, and I don't know what the technical term is, but they were basically sat under the ventilation system that then pushed the virus along this kind of corridor, and it affected somebody 20 feet or 20 metres away in the same building. And that was actually proven through the track and trace system. So when we keep talking about the ventilation, I think we have to be aware that there is still a risk to ventilation in something like that that's now been proven, but also in terms of when we talk about fresh air and windows open, it can actually move it around within before it actually takes anything out. So I still find that a concerning area that's coming through as public health guidance. Thank you.
And happy, Chair, to pick that up through the COVID control board, if that helps. Oh, you're muted, Chair.
Yes, thank you, Rupert. I'm just obeying the instructions that I gave myself. Okay. I can see no more hands raised, so I will ask, do board members note the presentation given by Dr. Suckling?
Noted, Chair.
Noted.
Thank you very much. If we move on to item 7, and that is what's the data telling us, I will now ask John Gleek, the Head of Service for Strategy and Performance, to present this item. John?
Afternoon, it's John's sidekick. I'm Laurie.
Sorry.
John's on leave today.
Oh, right, okay. Thank you, Laurie.
Is this visible to everybody? Can you see a presentation?
Yes, thank you.
On your screens. Excellent. Could you just excuse me? I'm just going to cough. Not a good sign, is it? Right. Okay. What I'm going to do is I'm going to give you a kind of slightly elongated version of the presentation I gave to IM&T about an hour and a bit ago, if that's okay. So I'm going to start with the 7-day case rate, which is the number of positive cases that have been identified in a 7-day period. And the latest rate that we're reporting is for the period the 12th to the 18th of January, which may feel like quite a while ago, but this ensures that Public Health England have actually captured all the positive cases that happened in that period. So there's a slight delay in it, but the delay means greater accuracy. So the 7-day rate for reported today is 267.7 per 100,000, which is a decline from the last reported rate, which was 276.7. So it looks at the moment, and I'll show you a graph in a minute or two, which will show you what's been happening. But on the whole, over the last few days, Doncaster's 7-day rate has been falling. However, our rate has tended over the past month or so to be slightly higher than our South Yorkshire peer authorities. Barnsley today was reporting 238.2, Rotherham 284.1, Sheffield 239.9. The Yorkshire and Humber average was 249.9, and as Rupert has said, the rate increases we saw in the third wave here in Yorkshire and Humber have been much lower than they were in other parts of the country, particularly the southeast of London. The England rate today is 453.6. Now, the other important rate we keep a very close eye on is the positivity rate, which is the number of positive cases as a proportion of all cases. And I think Rupert said that we would like that to be below 5%. It's currently 10.5%, which was a slight increase on the previous reported rate, which was 10.2. Just incidentally, we were past the 18,000 confirmed cases since the beginning of the epidemic sometime over the weekend. So I'm going to show you that, that I've just talked about, the case rate, but in a graphic form. The line to look at most closely are these purple dots with the red line. That's Doncaster's 7-day rate. And what you can see here is, much as with the England rate, which is in green, Doncaster saw a peaking of the rate, a slight dip here, which is actually explained by Christmas and New Year, where there was a dip in the number of cases reported, which explains what happened with this kind of strange smile effect here. But what happened is that we peaked around here, and then since about a week and a half ago, we have been reporting falls in the 7-day rate. Now, we've occasionally had a slight uptick, but on the whole, we've seen falls. And as you can see here, we've been in 1, 2, 3, 4, 5. We're about 6 or 7 days into reporting period of the second lockdown. What we've also done here is marked when the snow happened, because we were interested in what may or may not have happened as a result of the snow that we had last week. So Doncaster's rate has been falling. As you can see here, it's been slightly higher than our other South Yorkshire authorities, but it's fallen fairly consistently over the last few days. Possibly slightly concerning, we've noted that Barnsley, Rotherham and Sheffield have all, in the last couple of days, reported increases in the number of in their 7-day case rate. So hopefully that is not going to turn into a trend, but nevertheless, on the whole, the news seems to be good in terms of the 7-day rate. Looking more locally now, I'm not going to talk about that one. I'm going to talk about this one. Now, this is the local hotspots. Now, this is a piece of work that we do every Monday, which is to identify the areas of the borough which have the highest concentration of cases in the previous 14 days. And what you can see here is that we've identified 4 areas. We tend to refer to them as hotspots. It just means that there are more cases per sort of square 500 meters than in other areas. And the redder the spot are, the more intense or the higher number of cases in that small area. There are 4 that we're concerned about this week. There's an area around Stanley Square in Kirk Sandal. There's a large hotspot in the area which is between Lower Wheatley and Wheatley Park. Essentially, for those you know the area, it sort of straddles, is it Wentworth Road? I think it straddles Wentworth Road. And there are 2 hotspots in Conisborough, one in Conanby and the other in Cornhill, so almost at opposite ends of that community. On the whole, most of the communities in Doncaster are not seeing increases in the number of cases. There are some that are seeing slight increases, but on the whole, as we're seeing in Doncaster as a whole, the number of cases is falling in most of our communities. And sometimes what we will find is these hotspots actually occur in communities that are actually seeing reductions in the number of cases. So I'm not going to talk too much about this because this is more of interest to our IM&T colleagues, but just a reiteration of those 3 communities and those 4 hotspot areas. Finally, we also report to IM&T on the current state of hospital pressures. And today at midday, there were 154 patients in DBHT who are receiving or have received care for COVID. 114 are currently receiving active care for COVID-19, and there are 10 people in ITU currently actively receiving care for COVID. Now, if you look back over those numbers, what you'll see is that they are on the whole a slight reduction on the numbers we've seen since the beginning of January, which is good news. However, the ITU numbers, which have been around 11, 10 or 12 for at least the last month or so, are not coming down. So that is of some concern. But there isn't any evidence at the moment that pressure is building in the hospital. Well, that doesn't mean that there are other pressures coming into the hospital, because of course we are in the middle of winter, and winter pressures is something that's happening over and above the COVID epidemic. Right, the next few slides I'm going to bob about a bit, and I apologize for that. It's just I've come straight out of one meeting and into this one. I haven't had time to rearrange my slides into a more logical order, so apologies for that. This is, of course, the concerns we have over the new variant of COVID. I'm given to understand by Rupert that eventually all our cases will be as a result of new variant, as it's the nature of something that's more contagious and easier to catch. It will take over from the one that's less easy to catch. But at the moment, we have about 56% of our cases are identified as having the new variant. And as you can see, over the past 1, 2, 3, 4, 5, 6 or 7 weeks, that number has been increasing fairly dramatically. The number probably to take home, if you want to take one home, is the 52%. The 56.6% is based only on 3 days. So it's not a complete week. The number for the previous week, 52% for Doncaster, is the one you should probably think of at the moment. These data get updated every Friday, so these were reported the end of last week. But what you can see here in the blue line is that the rate in Doncaster is increasing at pretty much the same rate as our South Yorkshire Authority colleagues, but our rate seems to be slightly lower. So if I move on to the issue of age groups, this is important, of course, because of the impact of people aged over 60 and over 85 being diagnosed with COVID-19, as they are much more likely to require hospital treatment. What has been concerning us is how similar this third wave, which is here, was going to be to the second wave, which is here. Now, I apologise, some of these lines are a little bit difficult to determine, but the interesting line to start with is this yellow line. Can anyone see that? I'm just seeing you're nodding, so yeah, that's okay. The yellow line is people aged 23 to 34, so these are the young adults, and they in the last wave, in wave 2, led the way. They were the vanguard, if you like. They opened up the numbers of cases, and then very swiftly they were followed by 45 to 54-year-olds, and then later on by 35 to 44-year-olds. So these younger working age led the way. But what worried us initially was how quickly, within a week or so, people from 65 plus and people 75 plus, which are the brown line and the grey line, followed in the wake of those increases. Now, if you come here to the second wave, which is here, what you can see hopefully is that the pattern initially started pretty much as we expected. The yellow line, then the green line, then the blue line all took off. What seems to have happened is this doesn't seem to have translated into increases in cases amongst people aged 65 plus, because as you can see here, the brown line and the grey lines continued along pretty much a plateau rather than increasing as we had anticipated. This is not all good news. People in those age groups are still catching the disease, but the issue was we didn't have this precipitous rise that we were expecting, and that may, I'm only saying may explain why the hospital hasn't been seeing catastrophic increases in the number of cases of COVID and those cases going on to use beds. So at the moment, there's fairly good news. It looks like, on the whole, the rates amongst the younger working age are falling, and it looks like it hasn't taken off in the older age groups. Finally, vaccinations. We think there have been at least 20,000 vaccines delivered so far in Doncaster. There are a couple of data issues that we are exploring, but I think the data is accurate enough to share with you. As you can see, the second doses have stopped being delivered, but what you can see is all 5 sites are now delivering vaccines. And from about the beginning of January, that all those sites seem to be operational, up and running. We're still exploring how this data works, and we know there are some issues. But as I said, I thought it was worth sharing with you, as we're pretty sure there are 20,000 plus vaccines so far delivered to people in Doncaster. And finally, just to say that the yellow line, the orangey lines here are the numbers of deaths in which COVID was recorded on the death certificate, which is a shorthand way of working out the impact of COVID on our mortality rates. And what you can see, that it's a little difficult to tell, is that really since the beginning of December, the proportion of deaths that have been accredited to COVID have actually fallen. And so the number of deaths which have been had COVID mentioned on the death certificate have actually fallen, but they are still worryingly high, of course. There have been, as far as I think we last updated this on Friday, 804 deaths from COVID here in Doncaster. I'm going to stop there, but of course, Chair, I'm happy to take any questions.
Okay, Laurie, thank you for that. Have any colleagues got any questions to ask? If you have, can you raise your hand? That would be very useful. Thank you. Damien.
Yes, thank you, Laurie. Very comprehensive and interesting to particularly note the distinction in the differences between the second and the third wave, and in particular the relatively positive impact that's had on the over 65, not necessarily been at the forefront of that infection rate. I'm interested because Rupert referenced earlier the new variant, and you have too, in terms of the increasing proportion of cases, and that ultimately all will be new variant. That, given its increased transmissibility and also Christmas, I would have expected perhaps maybe more stacking, I think the phrase is, of the age ranges as a result of that, and just wonder why that hasn't happened. And it might be more a question to Rupert than yourself, Laurie, but I mean, it's the benefit of having the data that reveals such things.
Yeah, it played havoc with our modelling, I have to say, because it didn't, because we were assuming what models were going to work as the second wave. So yes, it was pleasing, but slightly irritating if you were trying to model what was going to happen next.
Okay. Rupert, I notice you've got your hand up.
Yeah, I mean, just in response to what Damien said, I think the thing for us is that we had the big rise in October, November. We were under tier 2. I said we were under tier 3 last time we were meeting, and that was holding the number of cases for quite a while. I think where in the southeast they saw a huge rise, they'd got no restrictions or very little restrictions, and they got overwhelmed very quickly. So certainly areas like the Isle of Wight saw a huge increase, going from sort of, no restrictions to essentially tier 4 in the national lockdown. And locally, we've seen that in York. So people will remember York was under tier 2 for quite a long period of time, and then their rates were almost twice what ours were over Christmas. So I think it's a combination of the arrival of the new variant and the current or the lockdown measures or the restrictions that were already in place. So the restrictions that we were under probably helped mitigate against that big increase. But it's true to say that it's still the basics are needed for the new variant. So it's still hands, face, space. Those are still the key things. And areas maybe that didn't have restrictions may have been more lapse on those restrictions, which allowed the new variant an opportunity to grow.
Thank you.
Okay, thank you, Rupert. Paul, I notice your hands raised.
Yeah, thanks, Chair. You have to bear with me, Laurie, 'cause I'm not sure how to pose this question. So there is a meaning to what I'm trying to get to in terms of data tracking and understanding the transmission. So I know there has been concerns from certain quarters about the accuracy of the lateral testing. And again, there's concerns around the track and trace system in general. But a colleague of mine at work had 3 lateral tests over the last fortnight, having been at Northbridge Depot. And then on Saturday, the last one he had was on Thursday. And then on Saturday, he started to feel unwell at the same time as his wife. Went to have a test yesterday morning, and they've both come back positive this morning. In terms of trying to understand or try and bottom out where the transmissions are, because we've got the hotspots of where the cases are, but obviously what we're trying to stop is the transmission to reduce those cases. Is there any way that we can track between people who've had lateral testing and then maybe full testing to understand where they are and where they've been, to try and sort of cut the transmission rates? Does that kind of make sense in what I'm trying to get to? But if people are testing negative, then suddenly positive, is it a case the testing's incorrect? And then from when you have a negative test, how long can it take before symptoms start to show? If he was tested negative Thursday, but then comes down quite heavy with his wife at the same time on Saturday, in showing, pretty much unblown systems of flu, cold, breathing, etc., to get the positive test back this morning.
I think I understand your question, which is a very good question. Unfortunately, I don't think I'm the right person to answer, because I don't know enough about the reliability of the lateral flow as opposed to the PCR. And I'm not sure that we have local access to lateral flow data. We may do. Rupert will know better than me. And we've certainly done no analysis on that. I think it's an interesting question. But unfortunately, I won't be able to answer it, because I don't have enough information at my fingertips to be able to answer that very well. But people who know more about the testing may be able to answer that.
So where we could take it though, Laurie? Sorry, Chair. Is it somewhere we could take it, Laurie, in terms of trying to maybe look at understanding it and putting something together?
I will certainly take that away and see what we can do. Rupert, I think, has got his hand up, so he may have a better answer than me.
Okay, thank you.
Yeah, so just in terms of the lateral flow test, I mean, they're pretty accurate given that we've got high prevalence, but it wouldn't be unusual to then test positive within 12 to 24 hours on a PCR, because that's the length of time it would take to test positive on a lateral flow. When somebody does test positive on a PCR, they have contact tracing, and they particularly look at the contacts in the last 48 hours, and that's our best chance of piecing together, Paul, of how things have sort of played out in terms of common exposures or working. We'll pick that up in the control board as well, because certainly we've seen recently a lack of information in the contact tracing data we get from the national team, Paul. So in terms of many cases not even have occupation or ethnicity, which does make that harder. So I think we would want to look to develop our own capability to do that locally, if that's okay.
Okay, Rupert, thank you. Andy?
Yeah, now just to come back, is it too early, Rupert, to ask the questions about the vaccination plan, or shall I leave it for a while longer?
I would suggest we ask Anthony to give us an update on the vaccination programme now, if that's okay, Chair.
That's absolutely fine.
He may answer your question, Andy, but if not, at least we've covered that off. Anthony, are you okay?
Yeah, I am. Good afternoon, all. Councillor Jones, I've just got a quick slideshow to show people, and then happy to pick up any questions at the end, if that's okay.
Absolutely fine, Anthony.
Thank you. I'll just you do the usual, making sure that this can share. He hopes. Okay, can you let me know if that's up on screen?
Yeah, that's appeared. Anthony,
okay, I'll kick in, everybody. For people who don't know me, I'm Anthony Fitzgerald, and I work at Doncaster Clinical Commissioning Group, and I'm helping to lead on the vaccination programme. I'm just going to take people through a reminder of the programme. Really, you'll have heard this from other avenues, but noted that this has started since the last meeting. Just remind people of Doncaster approach. I've got more updated numbers, Laurie, on where we are on vaccination numbers and their trajectories, and then some key messages and challenges, if that's okay. So just to remind people, the vaccination programme, seems a long time ago, but only started on the 15th of December here in Doncaster. So we haven't been going long, but hopefully what I'll get across is that we're going great guns. We're following the national rollout, and that's been clarified in recent weeks on what that means. So if you can see that diagram in front of me, the first cohort is care home residents and care home staff. The second is our population who are over 80 and our frontline health and care staff. Our third is over 75s, and our fourth is over 70s or clinically extremely vulnerable people, or you may know them as another name as sort of housebound people who have been kind of shielding through the lockdown process of COVID. Now, those first four cohorts should all be vaccinated by the 15th of February. And just to give you an idea of scale, there's around 77,500 people in Doncaster who fall under those first four cohorts. Now, the way that we've tried to address this in Doncaster, it's very much a multi-agency approach to this, involving all our primary care, our GP practices, Primary Care Doncaster, which you may remember is our federation, primary care networks, which are conglomerates of GP practices in areas working together, but also our hospital hubs now, so particularly DRI and R-Dash at Tickle Road are responsible for delivery of the vaccine to health and social care staff. So we have a multi-agency plan on this. It's currently just being refreshed, but I think we have got organisations across Doncaster working together on implementing this programme. So this is, it takes some getting used to, but essentially now we have 7 sites where we're administering vaccine from in Doncaster. I'll run you through them. In the east of Doncaster, that's Fawn Leisure Centre. In the centre of Doncaster, there is Rutland House, the Keepmoat Stadium, also the DRI site. In the south of Doncaster, there is Dearne Valley Leisure Centre, and also Tickhill Road site. And in the north of Doncaster, there's the Adwick Leisure Centre. Now, why run out of those areas? Well, it was twofold, really. I think, as Rupert's already mentioned, primary care and general practice continues to run as normal, well as normal-ish, as we're trying to administer the vaccination programme. And as you'll have heard, and I'll get onto the question from one of the councillors, the vaccine is in relatively limited supply at the moment. So we wanted to pick centres that were relatively accessible, hopefully accessible for people of Doncaster, but also could be administered at scale rather than at individual practices. We could maintain social distancing. There was car parking, and we were able to get vaccine administered in a relatively short time frame once it is delivered. So we asked about numbers. So again, I'll send this, Councillor Jones, I'll send this, make sure this presentation is available. Obviously, the numbers are changing all the time. But as at last night, we'd vaccinated just shy of 32,000 people in Doncaster. The good news on that front is we've vaccinated all the older care homes residents within Doncaster and their staff, with the exception of if at the moment or there was an outbreak in that care home, which meant that we hadn't been able to get there really to administer the vaccine, but those are quite limited. We've vaccinated around 80% of the over 80s, and as I say, those people will be vaccinated by the 15th of February. And we've made a start now on health and social care staff, around sort of 30% of staff vaccinated, and obviously there's a big ramp up on that over the course of the next 3 weeks. We're now very much going into the cohort of the over 70s as well to meet that deadline. Across South Yorkshire and Bassetlaw, so outside of our area in Doncaster, you may have heard today that the mass vaccination centre at Sheffield Arena went live, and those centres are available to start inviting our over 70s population, if they so choose, to go and have their vaccination there. There also are a number of pharmacy pilots across the country. So these are pharmacies opening up to try and vaccinate people. The closest one to us is in Wakefield. And what I should have said at the beginning is that there's 2 types of vaccine that's being administered at the moment. You'll have heard of the Pfizer vaccine, but also AstraZeneca. And the AstraZeneca or Oxford vaccine is much more transferable across sites, and we're potentially now, probably post the 15th of February, but potentially now looking at moving AstraZeneca into individual practices, particularly in those areas where that aren't as accessible for our residents and our population. But we're working those up with the clinicians at the moment. So if I quickly get on to the challenges, you've rightly mentioned supply. Obviously, this is an issue across the country. In Doncaster, at the minute, as things stand, we wouldn't have the projected supply to meet the requirements for the 15th of February. I suppose all I can say on that is that we're escalating hourly and daily in terms of ensuring that we do have enough vaccine to meet our requirements. And fortunately, really, my boss, Jackie, sits on the sort of regional delivery of this programme, and I'm able to escalate to her accordingly to increase the vaccine. It's going to be a tight run thing, in my opinion, on supply of this, given that we've only got 3 weeks to go. The assurance that I can give is that as soon as we get the vaccine, we are administering it. There's no stock or storage anywhere in Doncaster. Certainly for the Pfizer, of course, you can't store it. But as soon as we get our vaccine, we're putting on the clinics and getting to people accordingly. The second challenge has been the changing of guidance, and you'll have heard of this between Christmas and the New Year. So the original guidance for the Pfizer vaccine is that the length of time between the first and second dose was to be at 3 weeks. That changed. The advice from the scientists, and that changed to now a 12-week period between the first and second vaccine. Now, you may have heard from some of your residents that they may have had their appointment cancelled, and we had to deal with that accordingly. I'm sorry that people had gone through that sort of process. We tried to handle it as much as possible. What I can assure people is that anybody who had their first vaccine will have their second within the 12-week period. I've mentioned care homes and our ability to get them if there is a COVID-19 outbreak. As I say, that's been relatively limited, but we are managing that process. And then booking challenges for hospital hubs, that's really just an operational issue that, as I say, there's over 21,000 health and care staff across Doncaster, and it's obviously a monumental challenge to ensure that they can be released from their workplace to get over to one of the hospital hubs for them to have their vaccination, but we're dealing with that accordingly. And then communication messages. Whilst it's good that we've got the mass vaccination sites up and running, we aren't in charge locally of that booking process. So that comes from the national systems, which means there is a potential for some of your residents to get an offer of 2 different places for their vaccination. That's a message that we've got to manage, and we're trying to do a lot of work with our comms and engagement teams. And I think you'll have all received a briefing last week that I helped put together. The message that we're trying to get across is that if a resident does want to have their vaccination locally, they will get an offer before the 15th of February. If they are able to travel to Sheffield and want to have it any sooner, then they are able to take up that message as well. So finally, Councillor Jones, just quickly, key messages. I think we've had a great start. We've had a great take-up. We haven't seen a vast amount of people not wanting to have their vaccination. We've seen very, very little people not attending once they've had their appointments. We had a few problems in the snow a week or so ago, but the good news is we've wasted very little, if any, vaccine that's been delivered. Fantastic effort from staff and volunteers across the system, and I think councillors have been offered the opportunity to do some marshalling at the sites, which is very much appreciated. It's a key role, so volunteers are playing a key part in this as well. And then finally, managing messages and expectations with the public. We are trying to get across, don't contact the practices will contact you, and they will contact you before those dates. Keep the appointment if you get one. And then the vaccine, as Rupert I'm sure will remind everybody, whilst it's a way out of this, it doesn't at the moment stop the chances of people who have been vaccinated passing this on. So we must ensure compliance with lockdown and public health guidance. I've rattled through that, but I'm happy to take any questions.
Thank you, Anthony. Yes, I did notice that Mel had her hand up earlier. It's gone down. I don't know if part of Anthony's presentation covered that, Mel, but there's no indication.
Yeah, it got covered. I was just interested in relation to the sort of refusal rates. That's all, but I think it got covered. Thank you.
Okay, thank you, Mel. Are there any questions from anybody else? Dolly.
Thank you, Anthony. I just wanted to find out about the vaccine, the Pfizer and the AstraZeneca one. Do people have a choice as to the one they are going to take, or we we just go there when it's our turn, and then we have to take whatever is administered. Because I've had, there's been a lot of things going on about all this too. So I'm just trying to wonder how we can try to prevent, because I know the first group that's been administered and the health officials, most of them, because obviously the older ones are very vulnerable, so they are willing to take it, and then the health officials. But as it goes down, from the middle age to the lower one, a lot of people are still skeptical about it, and there's still a lot of issues going around about all these theories. So I just want to know if people have a choice, or when it gets to our time, we just go there as a zombie, and then you take whatever is being offered, and that's it.
No, that's a good question, Dolly. I mean, the short answer is there isn't really a choice, because often we don't get a choice on what centres. So we administer really what's there at the sites. Mainly, a way of sort of summarising this really is that generally the Pfizer vaccine has been administered from the hospital hubs, because it only keeps for 3 days, for want of a better word. The Oxford vaccine, as I said, is a bit more transferable, and that's been where we've taken out to housebound people and care homes, etc. So generally not a choice. The other thing to note, Dolly, is that if you have both for both your doses, so you have one for both your doses. So if you had Pfizer first time, you need to have Pfizer second, and vice versa.
Okay, thank you.
Thank you. Jane.
Yeah, just a couple of questions, Anthony. Obviously, what do we advise our residents when, obviously, I had a resident last week saying that his elderly father had been offered his vaccine. His father's got dementia, and it was to take him to Ripon. Now, I've had a couple of cases in my family like that, and also some people can't understand, unless they chase up, why they can't have the vaccine. And I found out that was to do with that it doesn't suit all the medication that some of our elderly residents are on. So, like, I've got an auntie that obviously has certain medication, and the vaccine isn't suitable for her currently. And my other question is like, basically, I'm of the, shall we say, 55 upwards age group, and I've got what's classed as an underlying health condition. But looking at what you've just shown us, when would you fall into that category before the normal 55s or the 60s?
Okay, thanks, Jane. I'll take those in turn. For the person who was contacted from different areas, again, the message that I would give is that if people are willing to travel to have their vaccination quicker, there is an opportunity to do so. But if you can't, you will be offered a local appointment. So, for example, the person that you mentioned there around dementia, their ability to travel, my advice would be wait for your local appointment, because you will be contacted for that. Second one around exceptions. Yeah, I'm not a mass expert in this one. I have to admit, I know there are some exception. But what I can do, Jane, is get a bit more clarity on that, if that's okay, about who falls under that category.
We do get, Anthony, asked the question, why have they had it and I haven't? And obviously I understand, because obviously I've had the situation within my family. But it's when a resident contacts you to say, well, my husband's having it, but I haven't. Yeah,
and what we've tried to do is keep a sort of running FAQ on this, frequently asked questions on this, Jane, that we've tried to get circulated as much as possible. So do you mind if I go back and look at the clinical exceptions for that and some more information? And then your third one, don't know. I think there will be some more refinement of that ladder that I showed, into the next cohort. Obviously, there's a lot of noise, isn't there, around sort of other professions and that sort of that. So I think more to come on that, Jane. Once we go further down that cohort.
Just that I was willing to volunteer, like as a marshal, and I did say I would do it, and then my sons have put the foot down. said no way.
All right.
Thank you, Anthony.
Okay, thank you, Jane. Damien.
Yeah, thank you, Anthony. First of all, thank you and everybody else. We know it's a Herculean effort, and it doesn't stop for the snow or the floods, which is to be congratulated on. Three quick questions. You may recall, or Jackie will, that at previous meetings we've talked about the susceptibility of minority groups to COVID. And good news is that it was announced, I think, formally this morning that we're part of the Community Champions rollout, particularly dealing with vaccine hesitancy, which is obviously an issue in terms of ensuring that we meet those vulnerable groups with the rollout of the vaccine. Second question, which is more around the headlines around the redistribution of vaccine south, the levelling down agenda. Or whatever. What level of notice are you getting around redistribution? Because clearly you're already pointing out that supply in itself is the limiter. And if part of that supply has been limited for redistribution because people are expected to catch up with the cohorts, then that's of some concern. And the third one is the social care staff priority, which we know is expected to be done by the end of January. Via the hospital hubs, and you showed us the three types of distribution points. Is that solely linked to the DRI, or could Tickhill Road assist with that, where they've got capacity? Because it's otherwise, if you're not careful, again, we'll be issuing on the basis of availability rather than prioritisation of frontline staff.
Thank you. Thanks, Damien. So on the first one of the minority groups, yeah, we're just about to go through a big sort of engagement drive on this, utilising the networks that we've got already. So our BAME network, and also the groups that we've got already. I'm starting to look at some data. It's not brilliant in terms of recording, if I'm honest, in terms of minority groups, but right to point it out, Damien, and a big push over the next 3 weeks. Redistribution. Well, I mean, if I gave an example, we found out today what the deliveries would be for the week beginning the 1st of February. So essentially, we're talking, what are we, a kind of week in advance of what vaccine is being delivered where. We have put ourselves, we have basically sent the message that. And we're starting to pick up conversations around South Yorkshire, particularly now, around redistribution if we need to. And the message is that we'll pick it up at any short notice and be able to put the rotors on accordingly, invite people accordingly, so that none is wasted. So as I said, it's a whole case of escalation and being ready at short notice. If we can. And what I would say is that our population have reacted incredibly well to any short notice clinics that we've put on. And then finally, yeah, the health and social care staff. Damien, the deadline on that, we're increasingly being told, is pushed to the 15th of February rather than the end of January, which is obviously a help. We have a provider group set up that looks at who can do the vaccination and when. So we are increasingly wanting to involve the Tickhill Road site now that they've mainly vaccinated their own staff at Ardash. That is some availability now. We hope to get some more health and care, social care staff through that, but also maybe some use of our primary care sites as well. To me, it's about using whatever avenues we've got available if we can get the vaccine there to get people done in such a short time frame.
Thanks very much. Really helpful.
Okay, Jane, your hand's up.
Hi, Anthony.
Hi, Jane.
I just wanted to ask a quick question about adults with learning disabilities and whether or not they are going to be pushed into one of the cohorts, or are they going to be left down to their age? Because obviously there's new study, isn't there, out today, that they're 6% more likely to die from COVID.
Absolutely. So we have pushed this back. This is some of the conversations that we've been had on a regional basis, particularly looking for the next cohorts, Jane. So I would say, you know, when I said care homes, at the moment I'm talking elder care homes. So we need to think differently how much we can you know, obviously it would take more for our roving teams, you know, more specialists sort of going in and doing that. Sorry, Rupert, do you want to? Yeah.
Yeah, I mean, my understanding, Jane, is that there'll be a sort of levelling up sort of agenda applied here. So obviously learning difficulties, disabilities can be a broad spectrum. So if you need care and you're on the shielded list, you're in the top 4 groups, and those people should be vaccinated in that group. If you've then got a serious underlying health condition, you be vaccinated in that group. Otherwise, it would be your age. But you should go to the highest category that you're eligible for, rather than drop down to the lowest and just wait for age. That's my understanding. But I think, as Anthony said earlier, once these top 4 categories are being done, there's likely to be further guidance coming out in terms of what the next sort of set of prioritization looks like. So we are hearing there's lots of lobbying going on from unions, workforces, that they might be prioritized. I'm very nervous about that. I think every time you prioritize a group, you deprioritize another group. So my advice is to stick with the JCVI, but ultimately that'll be a national policy decision. But for learning disabilities, you should get treated in the highest category that you are that you're eligible for.
Okay, I can see no more questions. So if I can thank Laurie and Anthony for their presentations, and we'll move on to item 8, which is the COVID control plan version 7. Rupert, do you want to run through this item?
Yeah, I thought I'd take you through it line by line, Chair, if that was all right.
That's wonderful, thank you.
So, yeah, well, you'll remember that one of the things that the COVID Control Board has to do is to have a outbreak control plan, and that needs to be publicly available. You can gather it's probably been a moving feast with the changes in national guidance, national approaches, but we did think it was time that you saw the whole version here. Obviously, it's going to be subject to more change. There are a few areas that are just worth you knowing about. So Damien's already picked up under section 6, the vulnerable people, places and settings. We've got additional resources from MHCLG, the community champions. The outbreak management protocols in section go through a regular review. So learning from outbreaks, updating the approaches. Section 8 around community transmission. This is where we add in the national tiering guidance, and what we'll be looking for coming up, Glyn, is what the step down arrangements would be and when they would come into play. So they would be superseded there. Since you last saw this, we've added section 9, which is about local contact tracing. And section 10 is about testing. So just to remind people, if you have symptoms, you can organise to get tested at the airport testing site and at the park and ride at Woodlands up in the north of Doncaster. If you haven't got symptoms, there are a number of ways that testing can happen. So it can happen through workplaces. So health and social care workplaces have got access to testing. So have secondary schools, and from this week, primary schools will start to see arrival of rapid testing. As a council, through the Director of Public Health, we've got access to rapid testing, and there's a testing site at Mary Woollet, and that is open currently to frontline council staff and frontline staff and partners, so including police and fire service. We've also opened that up to primary schools and early years before they get their rapid testing. And then we've got community testing. So this week it's being launched at Stainforth. Hexthorpe launched last week, and Conisbrough is going to launch next week. We're also looking to bring in additional testing for people with symptoms in the centre of town and also then in Thorn. We're going to review what the situation is in Mexborough. So Mexborough traditionally had good access to testing when we had the testing site at Dearne Valley, but that's obviously now a vaccination site. So we just need to review that, Chair. And then final couple of areas just to flag to you. One is about the communication. So the way that that sort of changes depending on what the key messages are we want to communicate. But I think it is time for us to review some of the governance, Glyn. So be useful if after this meeting you're okay if you give me an action to review the governance and the membership for this group, as well as the Team Doncaster Golds looking at its membership too. So I'm aware that there are a number of people that maybe are on more than one group, and people might want to sort of rationalise their attendance. So you've got the outbreak plan. We'll keep updating it, but this version will go on the website. But if you're happy for me to look at the governance, I'll do that for you, Chair.
Thank you, Rupert. Okay, any questions to Rupert? If you can indicate your hand, that would be really useful. No, I've given you 6 seconds there. There's more generous than Damien. Okay, can we note the presentation by Rupert Suckling and also that action that Rupert is going to take away regarding the governance and membership?
Notum, Chair.
Thank you, Jane. Thank you, Andy. Right, we'll move on to item 9, the COVID Health Protection Board risk. Rupert, it's down to you.
Thanks, Chair. So the two areas that are very high risk on the risk register, not surprisingly, are the impacts of COVID on the health service. So although Laurie has said that they are managing relatively well, there are more people in the hospital with COVID than there were in the first wave, and that is having an impact on the ability of the hospital to carry out routine surgery, some outpatients appointments. So it's definitely important that we're still monitoring that. We would expect that to start to reduce in the next couple of weeks, though. So that's one to look out for. And then the second area that's high risk is testing and contact tracing. So testing, as I've just described, there's quite a lot of changes happening in testing, and I think that is a risk in itself in terms of making sure that the public are aware of what the options are for testing and how best to access testing. But the other element in that is the contact tracing. So when we established contact tracing, it was on the basis of between 35 and 40 cases a week would come to the local team to do. Last week it was over 180 cases, so 4 or 5 times the demand on local contact tracing than was needed. We've managed that by deploying our bank staff. So we've got a bank of staff that do contact tracing. We've also reprioritised the work of the public health team. So every member of the public health team now gives 2 days a week to contact tracing and outbreak management. All the other risks are being well managed. In particular, the support and welfare for vulnerable people. Since the national lockdown, obviously shielding has recommenced for people. We've done a piece of work to contact everyone who is shielding and ask if they need additional support. It's very similar position to the national restrictions in November, where the majority of people have got their own approaches to food supply and medicine sorted, but people are definitely still benefiting from the social support and that sort of human interaction. But otherwise, all the other risks are and impacts are being managed effectively, Glyn. Happy for any questions on that.
Okay, thank you, Rupert. Colleagues, do we have any questions to ask Rupert on this matter? Can see no hands raised. So with that, Rupert, thank you. Can we, as board members, note the presentation by Rupert?
Noted,
Chair.
Thank you. Okay. Moving on, item 10, minutes of the COVID Control Board that was held on the 6th of January. Rupert, again.
Yeah, thanks, Chair. So we agreed at a previous meeting we would bring the minutes of the control board to this group, so you can see the breadth and depth of the conversations. I think through this meeting we've covered the data updates that you see in the minutes. We also had the update on incidents. Fair to say, we still have a number of incidents in care homes, health settings, and in education settings, as well as businesses. And then at that meeting, we spent a long time looking at the outbreak plan, which we've just discussed with you, and then we reviewed the threat and risk. And at that time, on the penultimate page of the meeting, Steph produced an update around the communications, and in particular, I suppose, we flagged the issue around enforcement and the ability to increase our communications about that. So there's some work going on between the council, environmental health services, and the police in terms of making sure that where enforcement activity is happening, that people are aware of it. It's not that we believe that a stick is necessarily the best way to manage this, but certainly it is useful for people to understand that there are enforcement powers and that people are using them when that is the last resort. But that's the key update from those notes, Glenn.
Okay, thank you, Rupert. Do colleagues have any questions to again ask of Rupert? Okay, I can see no hands raised. So as ever, Rupert, you've given a full and comprehensive answer to everybody within your presentation. Okay, so can we note the presentation by Rupert, colleagues?
Noted, Chair.
Thank
Noted,
you.
Chair.
Okay, I'd like to now thank everyone for their attendance today and for their input. I will now close the meeting. Thank you.
Thank you.
Thanks, Glenn.
Bye, everyone.
Thank you. Bye.
Thank you, Chair.
Thanks, Glenn. Bye.